You go to Amazon, you look at the star score, you look at the price, and that's what you do to make a decision
Mhm.
about what to buy. Healthcare has had none of that. There's been no star score, there's been no reliable pricing. It's all been just a black box, and you just sort of like blindly wander into a doctor's practice and hope you're not going to get charged an arm and a leg.
Thanks for tuning in to the Self-Funded with Spencer podcast. Let's go make healthcare better together. Well, nice to sit down with you, man. Thanks for making the trip up from Austin.
Yeah.
Quick intro of yourself, if you don't mind, and then what do you guys do at GAM, and then we'll get into your backstory.
Yeah, Will Bruhn, CEO, co-founder of GAM here. My background is really in the healthcare quality space. Started out of Johns Hopkins. My kind of my passion in going through medical school and then afterwards and doing some research was how do you identify physicians that are practicing good medicine? That was kind of my thesis of what I wanted to go after, and so spent the last 10 years both on research as well as doing the scam initiative, looking at that type of subject, and been doing GAM for the last 6 years. And essentially what GAM is a large consortium of physicians, and we feel like the quality industry and the way that we were measuring quality was really antiquated. And
Okay.
so GAM was really born out of this idea that there's other ways we should be measuring quality that help patients get to the best care. And we really feel like transparency in the quality of care delivered should be something that patients have access to.
Yeah.
And so that's really been the journey we've been on for the last decade. Started out of Johns Hopkins as sort of like a research initiative. Dr. Marty McCary and I were doing a lot of papers writing around, quality of care and appropriateness of care. And then we decided just to run a little bit faster and partner with organizations. We decided to make an off-campus entity called GAM.
Okay.
And
What
so
is GAM as an acronym? What's it stand for?
it stands for Global Appropriateness Measures. And so
Okay.
our sort of like the thing that we're most known for is we've pioneered this idea of measuring the appropriateness of
Yeah.
care. And so that's really where a lot of our start was. And then we've now formulated into more of like a holistic quality of care company. So we do a lot of analyses to understand what kind of quality of care is somebody delivering, and then would I recommend my mom to go to that physician? And so that's a lot of what we
That's
do
a
now.
pretty good barometer, is like,
Yeah.
would I recommend my mom to go? And I think I really want to dig into the appropriateness, because I think that metric is what initially intrigued me. I was telling you, I read The Price We Pay a couple years ago in preparation for Dr. Marty McCary coming on. And there was some, excuse me, some appropriateness like measures in there that shocked me,
Yeah.
of like what some of the stuff people were doing, physicians were doing, that were so far outside of the norm of either frequency or going straight to surgery. It was kind of shocking,
Yeah.
honestly. But you have the distinction, right, Will, of going down the path of medical school, think you're going to be a primary care physician, and then once you get done, go, nah, I'm not going to do that
Yeah.
anymore. So why don't you tell us how that happened?
Yeah, my mom does not like this story. She thinks I wasted about a decade of my life doing all this. But yeah, like I said, a lot of my focus, even during medical school, I saw a lot of things happen in clinical settings that felt wrong for the patient. You come into medical school and you've got this bright-eyed dream that you're going to change healthcare and
Hmm.
you're going to save patients' lives. And the first kind of orientation of med school, everyone's just like excited to be there and we're going to wear our scrubs. And I think as you go through the system of med school and residency and training, and you start to actually learn how the healthcare system is set up, some of that like twinkle in your eye starts to dim down a little bit. And
Yeah.
so some of those experiences for me were really, mostly in different surgical settings. I'd be in in a different clinical rotation, and I would see a provider, or I would see the hospital that I was working in make decisions that were not right for the patient, but were best for like the bottom line for the hospital. For instance, one of the first clinical rotations that I was in was in internal medicine. And so internal medicine, you're doing a lot of rounding in the hospital, seeing pretty sick patients, pneumonia or post-operative patients. And one of my first patients I saw was this really sweet older lady. She was in there for a variety of reasons, but one of her high risk things was she had a high risk of developing blood clots. And so,
Okay.
so one of the things we ordered for that to just make sure that no blood clots were forming was what we call bilateral ultrasound of the extremities. So you take an ultrasound, you look at the arms and the legs. And I remember clearly I ordered this test, and the radiology team came in and they took out their wand and they did the left arm and the left leg, and they kind of scurried out of the hospital room pretty quickly. And I was like, I think we ordered it for both sides of the body. So I ran out there and I was like, "Hey, we ordered this for both sides of the body.
Yeah.
Like, what? Why didn't you do the right side?" And they said, "Well, we only do one side of the body per day." And I was like, "How does that
What?
make any
Yeah.
sense? Like, you're already in here." And come to find out, the head radiologist told me, they were like, "You don't really get out of this works. We only get paid for half the body per day. And so if you need a bilateral scan, we'll do half today and then half tomorrow." And I was like, "Well, what if she develops a blood clot in the next 12 hours? Like, that's a terrible thing for the patient." And so I just
Not
unfortunately had a lot of these
not to mention,
experiences.
how much time would additional time would it have taken to
Yeah,
do the
90
other
seconds,
side? I mean,
yeah,
come on, like that's
exactly.
absurd.
So you have these experiences when you're going through medicine, and obviously there's a lot of amazing people in medicine that are doing the right thing for their patients, but you see these outlier examples, and so as medical school started to wind down, Marty and I had started this GAM consortium and working with different groups and bringing transparency to the marketplace on quality. And, I just had my own moment where I was like, I feel like I can go one path of seeing individual patients and that being my life and making an impact there, or I see an opportunity to maybe impact millions of lives by helping people get to the right doctors based upon the analyses that we can perform. And so it just felt like a bit of like a calling moment where I
Yeah.
felt like this is what I'm supposed to do. And like I said, my mom's still doesn't understand why I did 10 years of training to not be a doctor,
Well, I
but
hope when she sees you on this podcast, because I
that's
know
right.
she's going to watch, she's going to go, "Oh, now I get it. Now it
That's
makes
right.
sense to me." But do you feel like you could see the trajectory you were on? I think you mentioned you might have wanted to go down the path of direct primary care, right? Which I think that's a noble path to go down. And I think that model, in terms of primary care, is the preferred option versus fee for service. But could you kind of see the eventual path you were going to go on there and say, "I don't think that's actually going to be the life I thought I was going to lead"?
Yeah, absolutely. I mean, I think direct primary care is one of the small examples of like where there is like hope in medicine
Yeah,
of
agree.
practicing. A
Agree.
lot of primary care doctors are so burnt out. You're seeing 30 patients a day, 8 minutes each, lots of paperwork. Direct primary care is kind of a way out of that. And so that was what was attractive to me about the DPC model. But yeah, I would say just a lot of other areas of medicine that you think about going to the typical fee for service model, you're just in a lot of different specialties, you're just kind of ground down during residency and
Mhm.
fellowship and training. And, even then your lifestyle afterwards is still not great, even though you're making better money. And so yeah, absolutely. I feel like you get this purview of medicine where you're like, this is not what I thought I was signing up for.
Yeah.
And so I think a lot of
Well,
students end up being
and to me, there's
disillusioned.
a part of me that thinks that's really unfortunate, right? Because obviously, I think you would have been a talented and great doctor if you'd gone down that path. And you saying everybody that goes to the medical school on day one is so enthusiastic and bright eyed and bushy tailed. And I'm sure the system ends up breaking a lot of people as a result, that whether they persist and become doctors or an area of specialty they pursue, or whether they do something else, but you don't want a system that burns out the brightest people to do good work. And that's really a sad kind of state of
Exactly.
indictment of the system of itself. But you mentioned earlier that GAM was a consortium,
Mm.
right? So was it mostly research being done early days? And I'm sure there's a lot of data you had to collect, but give me the early days versus what the business is actually now.
Yeah, yeah, great question. So we started out as a research initiative, and we had received a grant from. There was a big campaign in the 2010s called Choosing Wisely,
Okay.
and Choosing Wisely was a campaign that was supposed to get um, these specialty society groups together to create recommendations about where there was low value care being delivered in a given specialty. So like all the expert cardiologists were getting together, and they were saying the top 5 areas of waste in cardiology are everyone's getting too many echoes and cardiac MRIs and stents. And there was no action component to it, though. It was just sort of like, here's all the bad care. Good luck out there.
Hmm.
And so we received a grant from the same group to do part two, which we called Improving Wisely. And in that initiative, the whole goal was let's use this idea of bringing consensus from medical experts to create actual measures that identify the low value care at the individual provider level. And so that was the distinction. And we were able to actually take in healthcare claims data and identify the doctors and the providers that were delivering this low value care.
Okay.
And the early days of this was we were sending out letters to providers letting them know, hey, we created this measure. You're an outlier on this measure. As a courtesy, we just want to let you know.
Hmm.
And our whole goal is to see, is there some Hawthorne effect that now that they're being watched, there's going to be some change in behavior that they're
Explain
going
the
to.
Hawthorne effect. I think I get the
It's really,
context, but
yeah, it's
yeah.
just a it's a psychology theory that if somebody's being watched, their behavior will change.
Yeah.
And so we thought that, if somebody knows, oh, there's somebody watching my data, that they will change towards doing the right thing for
Mhm.
their patients. And that first study we did within Mohs surgery, which is a skin cancer procedure, we saw 83% of outlier doctors change their behavior. And that actually saved, over a 3-year period, saved Medicare $92 million.
Jeez.
And so
Okay.
that was a really cool pilot project to see, oh, you can actually create new quality measures that identify really big variations in care being delivered to patients that are in the appropriateness of care category. And you can actually do great stuff with that data.
Yeah.
And so those were the early days. There was a lot of research, a lot of doctor outreach, trying to change behavior. And now, fast forward to 2025, we are doing a lot of work around using this data to power different care navigation solutions. So we plug in with a lot of groups around healthcare, like Lantern, like Hinge Health, like Accolade, to supply data to them on quality of care so that they can direct their own patients. And then we also have our own care navigation solutions that we uh, license out to self-funded employers, TPAs, and groups like that.
Pareto Health is the largest benefits captive in the United States. With nearly 3,000 captive members, 1.3 billion of stop-loss premium in force, and almost 1 million covered lives, no other benefits captive comes close to Pareto Health's scale. But it's not just about the numbers. Pareto Health is a mission-driven organization, and that mission has 2 distinct parts. Number 1, to make self-insurance simple and more accessible for small to mid-sized employers. And number 2, to arm them with the most powerful cost management tools on the market. So if you're an employer frustrated with your healthcare outcomes, or you're a benefits consultant looking for an alternative to the status quo, it's time to consider Pareto Health. Pareto Health, where employers come to do self-insurance right, to do it easily, and to do it at scale.
I want to go back to the low value care situation you just described. It doesn't necessarily, at least in that situation, suggest there's high risk associated with the care being delivered. It's just there's low value in doing that test or that procedure. And there's probably incentive structure, I'd imagine, to incentivize that procedure being done because of the reimbursement model. And so
Exactly.
they get done too frequently, is simply
Mhm.
what you're saying, right? And so how do those doctors that were outliers react with that Hawthorne effect? Do they change their behavior? Did you see a pattern in which they actually came back closer to the norm after they realized it?
Yeah, exactly. So like our first project was in Mohs surgery, like I said, and
Yeah, what is that? So I
so
read the
Mohs
book, but
surgeon is
everybody
like,
may not know.
if you have, like, let's say, a basal cell carcinoma on your cheek or on your neck, the Mohs surgeon they essentially take these like tiny knives and microscopes, and they will resect the tissue around the cancer
Mhm.
and take it out so that you don't have to get like radiation and things of that sort. And so, um, what in talking to the experts in this field, what they told us with the low value area of Mohs surgery was that the Mohs surgeon actually gets paid per cut of skin they take out
Hmm.
in a procedure. So there's a perverse financial incentive to just cut straight through the cancer and therefore justify taking out a second, third, fourth, fifth cut in a single case and get paid a lot more for having an inappropriate
Would that have
practice
been at the
pattern.
same time, or would
Same
they come
time, same
back?
patient. Yeah. So they
But
would.
they're segmenting the cuts, right?
Exactly,
That's
yeah.
interesting.
Because sometimes you'll go in and you'll make it too narrow of a cut, look under the microscope, say, there's still some left on the margin. I got to take a second slice of skin out. So very normal and appropriate to take one, sometimes two, and rarely three or more cuts out. But the physicians know they're getting reimbursed per cut. So there's, not everybody, but there's a percentage of doctors that were, going in and routinely taking out 4, 5, 6, 7 cuts per case. And their reimbursement was off the charts for doing that. And so that's like a lot of the first focus was sending letters to these doctors just saying, hey, here you are on the bell curve. You're doing 5 cuts per case. The national average is 1.3. Just as a
What
courtesy.
gives?
Yeah.
Yeah.
Just as a courtesy, want to let you know, here's an email if you want to reach out. And I would say surprisingly, we kind of like when we sent out those 2,000 letters, we sort of like our research teams just like braced ourselves in our research rooms. We were just like, this is going to break
Angry phone
all
calls
hell
and
is going
yeah.
to come loose on us from these Mohs surgeons. And surprisingly, about 80% of the outreach back to us was very positive. It
Yeah.
was physicians that were just like, I had no idea that I was practicing so out of norm. Thank you for letting me know. Granted, there was that 20% that was like, screw you,
Yeah.
who are
How
you to tell
dare
me how
you?
to
Yeah.
practice medicine?
Yeah.
But even those doctors that were mad, a lot of them still corrected their behavior towards the mean. And so it was really cool to see that physicians would respond to that data.
Well, and even like when you think about correcting them towards the mean, there's questions sometimes about is the standard of care actually the appropriate standard? But this is
Hmm.
just simply saying we're looking at a population of most surgeons and saying the mean is X. Doesn't mean you have to be right on the mean, but you have to be within some sort of
Yeah,
like
there's a
delta from
range
it.
of
Yeah.
appropriate
Yeah.
care. Like medicine is an art. You're not going to practice the same as the guy down the street based upon your patient panel and so forth, but there's a range of what would be appropriate. And so if you're 2 standard deviations from the mean, that's probably a pretty good sign that you're doing something that is out of line.
Yeah. And then you don't want to suggest there's nefarious reasons for doing so. But if you're that far away from the mean and there's financial incentive for additional cuts, that's a logical conclusion you probably come to. Right?
Absolutely.
Yeah.
Yeah. Yep,
And
absolutely.
that's where I get really frustrated. And that's a circumstance, again, probably relatively low risk, but there are situations like a spine surgery or something to that effect that does have a relatively high risk associated with being too aggressive to go straight to surgery, right? So talk to me about spine surgery, because that's a very common one that people understand is sort of overprescribed in the
Yeah,
market.
absolutely. Yeah, I think we talked about earlier. Like a third of all spine surgeries in the country are unnecessary. How you define unnecessary is really difficult. It took us, I think we've met with 48 really high level spine surgeons to create our quality measures in spine. It's just a complicated, controversial space. But one of the areas that has been, really present over the last couple of years with our discussions with physicians has been when you have a low risk patient coming in the door that needs some type of lumbar operation done. Let's say you have degenerative disc disease or some other type of pathology where you need to get an operation on your lumbar spine. It's preferable if that patient is low risk, meaning they don't have some, sagittal plane imbalance, or they don't have some motor vehicle accident that happened, or other, kyphosis, scoliosis. If they're low risk, the preferred option for most of those patients is to get what's called a laminectomy,
Okay.
where you move part of the lamina of the spine, and that relieves stress on the spinal canal. It's a lower cost procedure, lower intervention. You're not fixating the spine for the rest of their life. You're not
Mhm.
putting hardware in their spine. But there's a financial incentive to do what's called a lumbar fusion, where you actually install that super expensive hardware
Yeah.
into the lumbar spine. It jacks up the cost of the procedure by 2 to 3x, and you're once again fixating that curvature for the rest of the life. So the patient is stuck in that position for the
Mhm.
rest of their life.
Mhm.
Higher reoperation rates, higher complication rates.
Yeah.
Not preferred if you're not supposed to do it, but a huge financial incentive to do those when maybe a laminectomy would be more preferable. And so we've done a lot of research around this topic, and it's interesting. One of the examples I always show when speaking at like conferences and stuff is we found these 2 spine surgeons that practice right next to each other in Pennsylvania. They see very similar panels of patients, very similar practice setting. One of them does fusions on about 10% of their patients, and one of them does fusions on about 95% of their patients. And the average cost per operation between those physicians is the difference is about $50,000. One of them is about 35,000, the other one's about 85,000 per patient.
Okay.
And so these are the types of things I feel so passionate about. Is like patients are out there just flying blind to these things. They're trying to choose a doctor. They're looking up on Google who's a good doctor, and
Mhm.
they don't have the right things at their fingertips to make these decisions. And so that's really where our group is trying to step in to say, let's bring transparency to the market so that people can actually make better purchasing decisions, so they don't end up in the hands of the guy that's going to fuse them 95% of the time.
Yeah, one of the most extreme examples, and I don't want to have too many specific examples, but I think this was the most shocking to me, was there was a doctor highlighted that was doing C-sections on Fridays, like 3 to 4 times as frequently. And it was always Friday afternoon, and everything was going to a C-section instead of natural birth. And, obviously C-sections play a role, and there is a percentage that should get it. But it was like, this was again, a couple standard deviations away from the norm. And you're going, why is it always on a Friday? What's happening? Well, logically, you presume they want to get out of there and go home. But like, what a perverse kind of incentive structure to say, I'm going to suggest to a woman that this is for the baby's best interest, or it's safer, or whatever. But really, you're doing it for yourself as a physician, most likely, so that you
Exactly.
can go home at the end of the week.
Exactly. Yeah. Our research team has looked at that exactly, which you see like C-sections spike on Friday afternoons, like you said. Like there's a pretty common rate of it throughout the week, and then like Friday at noon, it just starts to like do this like tailspin upwards. And yeah, the only conclusion you can really come to with that is either all the OBs plan their C-sections for Friday afternoons, the planned ones, like that seems unlikely, Or yeah, it's a convenience thing. They don't want to get called in at 2 a.m. on a Saturday to do a natural delivery. And so there's small nudges you can do to a patient to get them to go down a certain track, like you said, like making about the baby or the safety. And so yeah, these are some of the things that unfortunately are just a byproduct of having a broken system. I think we have really good doctors
Yeah.
practicing in a really bad system.
Well, and it doesn't even suggest that their skill or the quality of work isn't there, right? It's just simply the pattern of
The
choice that they're
appropriateness of
making.
the
Yeah,
care.
the
Yeah.
appropriateness. And then how do you, or if at all, how does GAM get involved in whether or not identifying something not only is inappropriate, but might it be fraudulent or something to that effect, or criminal, which is possible as well,
Yeah.
right?
Yeah, we've got about 300 of these measures now that our physician teams have built. And I'd say about a third of them fall into that category of if you're a far outlier on this particular area of medicine, you're probably doing something that is in the realm of like fraud or abuse or abuse, you know.
Yeah.
And so we have actually worked with the DOJ on certain instances, like in wound care, like we were talking about. We've also worked with some like independent attorney offices that had some like key tam litigation going on, and they reached out to us to say, "Hey, we saw this group of doctors in Phoenix were doing a really crazy amount of vascular surgeries on their patients. Do you have any data?" And sure enough, we did, and our data showed that they were far outliers. And
Hmm.
so our data has also helped, supplement some areas of like actual patient
Hmm.
harm and going after litigation for some of that.
Yeah.
So
ClaimDoc is a medical claim auditing and member advocacy company. We provide fiduciary services to employer-sponsored benefit plans and allowing them to create an environment where we ensure that the benefit plans are being charged on a fair and reasonable basis.
My business is basically people, and it become a real simple transition. We thought it was going to be far more complex. I've saved, we'll say, hundreds of thousands of dollars. I could not say enough about ClaimDoc.
Well, and everything you're describing has value to the marketplace, right? And so I want to get back to GAM as a solution and the application to it, whether that's employers, whether that's through a broker channel, like the actual brass tacks of the business and how it could be positioned for the folks that are listening. So why don't you talk to me about who's a common, if you will, customer of GAM?
yeah, since we've been on this journey, we've known we've been sitting on this gold mine of data on providers and like, the quality of care, the appropriateness of care that they're delivering. And the question has always been, how do we actually like go into the market to make this a valuable piece of information for people to use? And so we've been all across the board. We worked with health systems to do quality improvement. We work with health plans to do kind of network design and tiering. But I'd say most of the area that we see the biggest demand for what we do is in generally speaking, the self-funded employer space. And so there's a couple different ways we plug in there.
Okay.
We work with some vendor relationships like the Hinge Healths of the world that need quality information to navigate towards high quality MSK doctors. We also work with like the Lanterns of the world that want quality information on how to develop their network of excellence. And then we actually have our own suite of solutions as well for care navigation.
Yeah.
So that's kind of the main area that we've seen the best ROI and use case for our data is if we have a self-funded employer that has a desire to get their patients to a better, their employees to a better care, we have a whole suite of solutions that can come in to help their employees do that. So some of that looks like, an application, an online interface that you can search for doctors in your area. We'll recommend the ones that are highest quality and at the lowest price. And then we also have a nurse navigation team that will do active outreach to those members to make sure that we are directing them towards the better care when they are searching for care through like the prior auth system. And so that's generally where we've been most focused in over the last year or two has been that self-funded employer space.
Yeah, and I mean, it seems like an obvious application, and like things like GAM, whether it is GAM or something else in that category, seems very obvious to me to layer into a self-funded plan to get the most out of it, right? Because there's two components that we've discussed, which is the appropriateness and the quality. Appropriateness is, do you even need it in the first place? Because we fixate a lot on how do I lower the cost of the procedure, get them to the highest quality,
Exactly.
lowest cost provider. But what if that could be avoided altogether when somebody's sitting there and saying, I don't think that's the right course of treatment yet necessarily, right?
Exactly. That's a perfect example is most of the quality industry and most of the people out there that do kind of care navigation towards high quality doctors, most of the focus the last 20, 30 years has been on outcomes, which is after the surgery is performed, how well does that surgeon do? Do they have low complication rates, low readmission rates, low reoperation rates? And we do all those analyses as well because that is an important aspect of quality. But the blind spot that nobody's ever talked about has been the appropriateness of care. Does this patient even need that surgery? Do they need that scan? Do they need that prescription or blood test? And there's a lot. I think there was a study that came out that said about 21% of all medical care is estimated to be unnecessary. And
21
so,
in total,
in total,
21%.
across all specialties,
Okay.
about 21% of medical care is unnecessary. And so, if you can eat into that by getting to the right doctors that are doing the appropriate things for their patients, I think you start to see medical spend dramatically decrease versus just looking at the outcomes of the care that's
Well, back
already
to the
delivered.
napkin math, right? $4.5 trillion industry, 20% of that is $900 billion.
Exactly.
So let's round it up to $1 trillion.
Yeah.
That's potentially just completely unnecessary care whatsoever,
Yeah.
right? What could we do with a found extra $1 trillion we're not spending as a nation on healthcare that would make a significant impact? But I think that's still just a start, right? I mean,
Yeah.
if we could wipe away $1 trillion overnight just with measuring appropriateness, great. Then there's the next step, which is, okay, is appropriate care, but there's a broad spectrum of physician quality. There's a broad spectrum of cost of facility, et cetera, et cetera. Can we then also lower the cost of the care that is appropriate, but we just need to get them to the right setting? Right?
Exactly. Yeah. I think that's exactly the stepwise approach is get them to the right doctor that's going to give the appropriate treatment, high quality care. But then the next step is also let's make sure you're not overpaying for that service. And so the last 5 years have been really fun. I mean, some of your viewers might be surprised to hear this, but I think it's actually a really exciting time to be in healthcare. Like
Yeah.
there is so much innovation going on. I think the last 5 years have been super cool to watch the kind of price transparency revolution where now prices are becoming more known and there's a marketplace now of prices that you can shop for. And I think that's only going to become more popular. And I think the next step then is transparency on quality because in any healthy market, you need quality and cost to make a good decision. Like we said, you go to Amazon, you look at the star score, you look at the price, and that's what you do to make a decision about what to buy. Healthcare has had none of that. There's been no star score. There's been no reliable pricing. It's all been just a black box, and you just sort of like blindly wander into a doctor's practice and hope you're not going to get charged an arm and a leg.
Yeah.
And so I think it's a really exciting time to be in the space to really bring in, the tools that patients and everyday people are going to need that can actually make informed decisions.
Well, I was telling you, just like top of mind, because I was on LinkedIn this morning over coffee before you got there. There's a consultant posted about it. He's getting a knee surgery. And he's like, hey, I know I do this for a living. I wasn't sure what doctor to go to. I had to go get a second knee surgery. I picked the Dallas Cowboys knee surgeon. He's probably pretty good. And then, oh, by the way, I have no idea how much this is going to cost my plan. And so even somebody that is informed that does it for a living is still at the mercy of a limited amount of data to make a right decision,
Exactly.
especially if their plan is not constructed in a way that helps them. And so then you just get thrown into the wolves and you try to do your best. But hopefully the outcome is good, and then hopefully that bill is not gigantic. But chances are probably the bill is going to be pretty exorbitant versus what he got because he went to that Dallas Cowboys doctor, right?
Yeah. Some of my favorite moments right now in my career are like all my friends and family know me as like the quality guy now, and so I love like when
You are a quality guy.
Yeah, thanks, man.
From what I see,
yeah,
yeah.
exactly. A lot of friends reach out if they need to get like a surgery done or they need to find a doctor and they know I've got like this secret data that I can go into. And so it's been really fun to be able to actually like going back to the North Star of like, I want to build something that like my mom could use to find good care. It's like, it's been really fun to like see our data in real life, make that impact. Somebody goes to a doctor that we would recommend and it ends up being an amazing experience. They don't get the unnecessary surgery. They get high quality care. They speak well with their patients, whatever it is, and it's at a good price. And so those are just some of my favorite moments right now is like actually having, you're so deep in like the data on a lot of the day and weeks. And when you get to like rise up and actually see, oh, we're actually like redirecting. I think we currently have like 3 million lives in some way, shape, or form that are being touched by our data. And it's just like, feels like an honor.
Yeah, I have a feeling too. I mean, some days you get sucked into the minutia of, a sales job or just working in the weeds and you forget to zoom out and see the big picture impact of what you're doing. And so it's good to every once in a while take stock of that because I would like to see something like this become I don't know if open source is the right word, but democratized in such a way that it's accessible to anybody through any plan design whatsoever. And I know there's a long way to get to something like that, but there's times when I'll sit down with somebody and go, at least the value proposition in and of itself is so obvious that it should work this way.
Hmm.
But how do you get from point A, 3 million lives today to 300 million lives and make it just the standard of navigation in the country?
I love that. I feel like that's what I think about a lot is we're currently in this sort of stepping stone to doing individual contracts with self-funded employers that want to do this, or TPAs or other groups like the Hinges of the world. But yeah, my broader dream is I would love to make this publicly available information. Like that's the goal at the end of the day is how do we make sure that people have the transparent resources they need to make a quality cost value equation for getting care. And so I think that is the end goal. How far we are from there, I don't know. How do you do that without causing World War III with the doctors?
Yeah.
I don't know, but I would say that's sort of where our team's sights are set on.
Yeah, and then kind of, if you will, the network construct itself. You and I were talking over coffee of this idea of high performance tier 1 networks where in pockets of the country you can set up direct contracts, you can incentivize members of a plan to go in that high performance network, out of pockets waived, wrap it with a traditional network. And so worst case, they have normal copays and deductibles apply. That works in pockets, but it's difficult to scale across the country because of so much variability. How do you overcome kind of the geographic constraints to make it possible to do with any plan design and anywhere in the country as well?
Yeah, I think that really is the future over the next 3 to 5 years. I think there's been a lot of, in the care navigation space specifically, there's been a lot of carrot on a stick incentives, which is, hey, we'll pay you, the employee at some employer, hey, we'll pay you $1,000 cash to go to the right doctor. If you go to the right knee replacement surgeon that we're recommending, we'll pay you cash for it. And it's this kind of carrot on a stick approach that has some effectiveness, but you still see a lot of these kind of care navigation solutions have really low, usage across the board. And so I think the real kind of next step for the healthcare industry is to change the benefit design within a plan to sort of make it painful to go to the wrong place.
Okay.
Wrong place meaning either low quality care or a really outrageous price. And so like exactly what you said is, hey, let's waive the copay to go to high quality, low cost physicians and facilities. And then, hey, you're going to have a $500 or $1,000 copay if you go to this place that we don't recommend. And so I think that's where you really start to see the impact. And that's what we're working on with some independent TPAs and other groups is let's actually change the plan design so that we make it really at the forefront of the decision of where you're going to get care. It's going to be obvious. It's like, hey, high quality, low cost facility. I don't have to pay anything. Easy. Like there's not a lot of reasons why you wouldn't choose that versus, oh, I'll pay $1,000 to go get worse care. And so that's really, I think, where the industry is headed that I think I'm really excited about for GAM.
Well, yeah, and especially, if you think about current kind of regular plan design today, copay, some sort of co-insurance, a deductible that has to be met. Those deductibles are creeping up more and more as employers react to rising costs, and they feel, especially in the fully insured model, the only thing they can do is push more share onto the employee. Well, the employee's still paying more out of their paycheck every single day. And so what happens, that rising out-of-pocket exposure that they have ends up becoming a deterrent to access whatsoever. So that's a really bad incentive structure. But I think what I'm hearing is you're broadening the incentive structure on both ends to say right choice equates to no cost and or maybe even we'll cut you a check for $1,000 for saving us money, to the other side being a little bit worse than they're accustomed to today. So you broaden the potential of outcomes to make the choice obvious. Still voluntary, but make it obvious.
Still voluntary. You never want to force somebody to get care somewhere, but making it like it's a hard decision to make the wrong choice. And I think it's so clearly obvious also for the employer where it's like we have so much data that shows we can get people to the higher quality orthopedic surgeon that are, half of the cost of the average in the market. And that's going to, for a knee replacement, that's going to save an average employer $15,000 to $25,000 just by directing one patient towards the right care. And so if they're going to cut even a check for another $1,000 or waive the copay, it's like the ROI is so clear there. So I think that's what we're trying to push towards is a market where making the right choice is clearly obvious. It's kind of like if you go to Amazon and you would have to like try to find the wrong product they make it so obvious, like, here's a star score, here's the price. Like, they kind of make it obvious which ones you should choose. And I think that's where we need to head towards in healthcare.
Yeah, because I think sometimes you'll see employers that want to offer really rich benefits, and I actually applaud them for doing that. But I've come across employers where no cost share whatsoever to the employee, and I think that is unfortunately the wrong incentive structure in that you're not giving them any choice. They're not helping. Push them down the realm of making a good choice. You're just saying, hey, we care about you so much, nothing costs anything. Good luck.
Yeah.
That's, of course, going to lead to rising costs over time. And
Absolutely.
if the business has enough money to do so, great. But I would like, in order to achieve the waiving of cost, you have to make the right decision as a result of that.
Chronic health issues, surprise out-of-network medical bills, inflated medical and prescription drug prices. These issues cost self-insured employers hundreds of millions of dollars every year. Add to this the rising cost of care and potential for waste across the life of a claim, and it's clear that self-insured employers need innovative solutions that lower their health plan spend. At Valence, we've done just that, developed innovation that shifts the current paradigm. A complete and integrated ecosystem solution driven by data, one that manages and simplifies the complexity of medical claim costs. It is through analyzing millions of data points that we enable employers to realize and fuel cost-saving solutions. Valence experts come prepared from day one, targeting the fraction of claims that will drive the majority of health plan costs. That is how our team lives the Valence promise, engaging early and often for smarter, better, faster healthcare.
But I think, what are some of the constraints or headwinds that you're going to run into? Because again, this seems obvious from like at a consumer standpoint. The reality is you have hospital systems, you have carriers that are part of the equation, you have networks that they believe have value, et cetera, et cetera. And so it's not like they're just going to all lay down and say, yep, you're right, Will, you're right, we're going to fix it all overnight. There's going to be a lot of pushback, right?
Yeah,
So what are
absolutely.
you experiencing as kind of pushback right now?
Well, the big carriers, the big bukas of the world hate this stuff. Any type of alternative health plan structure is not, not popular with the large blues of the world. But I would say some of the pushback or some of the like headwinds that we feel are that the data is still hard to access on some level. We have the quality information on about 1 million providers, which is great. That's pretty good national reach on most shoppable specialties. You can't track everything in medicine. So there's going to be those cash pay clinics you have no data on. There's going to be all sorts of kind of edge cases where you just can't track provider performance. So that's going to be a gap in like maybe some rural part of the country, somebody's shopping for care and there's not really good quality information there. There's also the challenge of, even though the price transparency data has been released and is technically publicly available, it's still super difficult to use. They make it, these payers and hospitals have made it clearly super hard to make that data usable. And so our team, we've had a full team of engineers working on this for the last 18 months to try to make this data usable. And we've released some of those products and we have the pricing data live, but we still run into oddities all the time. And so the usability of the data is still difficult, but like I said, now is the time, I think, in healthcare that we've never had in America, which is we now have at least the option to have transparency in the marketplace.
Yeah. Well, so let's say an employer has said, I want to contract with GAM. We want to roll it out to our population. Like, what are some of the triggers that you guys would intervene, or are you proactively looking at the population to say, this is the targeted list of people we need to reach out to?
Yeah, some of the ways that we try to interject in the process to make sure that employers are getting good value out of working with us is, number one, if somebody's going through like a prior auth process, we can track that and identify, oh, this person's getting approved for even something as simple as like an MRI. Hey, we have data that shows this independent imaging facility is $400 for a lumbar MRI, whereas the market average is $2,800. So that alone is $2,400 savings to just directing that one MRI. All the way up to, the spine surgeon. And so if somebody's getting approved for a certain surgery or some service, our nurse team, as well as we have some AI technology that can track this to do automated outreach to say, hey, we noticed you got approved for a certain service. We would love to offer a reward for, taking our path in terms of like who to go get care for this.
Okay.
Because, there's always going to be the sentimental physician-patient match where somebody might have already seen a doctor and they're like, I've already seen them. I don't want to change. But that active outreach can bring utilization from 5 or 10% of people using it up to 70 or 80% of people using it.
Which is like, that is the like golden ticket, if you will, for the things that operate in this point solution space. And I do want to have your opinion on kind of like PEPA models and bolting on a dozen point solutions, but they all struggle to get utilization. The things don't work if people don't use them. And so whether it's effective communication, positioning of it, make it easily accessible through some sort of app or a wallet or something, I think the challenge for any entity like yours is convincing people, one, that you exist in the first place, the general awareness, and two, there's utility in doing so. And I think the third is the employer plays a role in whether they're incentivizing, persuading, communicating, however, to make sure the adoption is there. And that's always a struggle, right?
I would absolutely agree. Yeah, I would say most of what has caused some of these this point solution industry, I think a lot of what has hurt is, number one, I think the PEPM model is starting to die, and I think rightly so, in the sense that if your entire population is not using it, why are we paying for everybody? So I think there's got to be alternative ways to pay for these services, whether that's per use or percent of savings models that we've talked about. And then I think the other part of it is absolutely like the usage. It's like if you have a 10,000 life group that signs on for a care navigation solution and only 500 of them download the app and then only 50 of them use the app for anything, like why is that group paying $3 per employee? It's like that just to me doesn't feel like a fair thing to the employer. And you end up, the point solution vendor ends up getting paid more than they even delivered value to that organization. And so I think that's one of the things that we're really trying to do some sort of cutting edge things around to try to figure out, how do we actually get wedged into that patient journey to find out, how do we actually change behavior on the patient level? And I think a lot of that I actually goes back to, yes, there's cool things you can do with reaching out with the prior auth process or identifying the high risk patients and doing outreach there to try to drive down their risk. But once again, I think the future to really make it available and valuable is changing the plan design, where it's no longer you're trying to convince somebody to do something. You're just making it readily available to say, you can choose this path, which is free, or choose this path, which is painful.
Yeah.
And I think that is where you start to see the market shift and users of these point solutions start to see.
Well, I was having a conversation with somebody the other day about this. It's like, it feels like there's a race to be the front door to healthcare for the general population of the United States. But you have to change the behavior of tens of millions of people in order to accomplish that, to where would their first thought be, I have been told I need an MRI, or I think I'm trending towards a procedure, I need to go to GAM first, right? And whether that's GAM or a multitude of different businesses, we want something to be the first intervening point into the healthcare system, far in front of you walking in the front door of a hospital, right? And I think everybody's sort of racing to, how do you change the behavior of enough people to be that thing as the entry point to healthcare?
Yeah, and I think a lot of that is active outreach. We were talking about Converging Health here in town in Dallas. We have a partnership with them, which is really cool. And they do some awesome stuff around whole person risk score and identifying who are those really high risk people within an employer's population that are going to have, likely in the next year or two, have some very high expense thing happen to their plan. And so we have some cool ideas around partnerships around doing active outreach to de-risk some of those people. And that's going further and further upstream of, rather than navigating at the point of surgery, you're going backwards 20 years, hopefully, and saying, how do we get these people to not need that spine surgery in 20 years? And I think that's where you start to see a long-term effect of, curbing the healthcare costs.
Well, we've hammered a lot on the medical side, but my understanding is you do have some role to play in the pharmacy side as well. So how does GAM intervene with expensive medications or ineffective medications, things like that?
Yeah, we track a lot of things on the pharmacy side as well. There's a lot of abuse and overuse with medications. Things as simple but tragic as, overprescribing opioids after surgery. That's something that our team did out of Hopkins for when the opioid crisis was first, starting to be recognized. And so we have a lot of measures around like overutilization of postoperative opioids. We look at psychiatric meds, looking at overuse of antipsychotics. Are you using the right depression meds, anxiety meds? Are you overusing benzos and other high-risk meds like that? And then also on the like expensive medications front, we do a lot of work around really expensive immunotherapy drugs, chemotherapy drugs, even stuff like all the hot press around GLP-1s. We're trying to identify appropriate utilization of these drugs.
Hmm.
Because it's not like these drugs come out and there's almost never a use of it. But if, for instance, with multiple myeloma patients, which is a specific type of cancer, you can give most of these multiple myeloma patients just a generic bisphosphonate drug, which helps spare the bones of their patients. Or you can use this specialty drug called denosumab that is like 500 times more expensive. And there's no clinical benefit between the
Hmm.
two to choose denosumab other than the financial incentive. And so those are the types of things that we track, both on oncology, autoimmune diseases, as well as like primary care psychiatry, just to make sure that people are not overutilizing some of these really expensive
Yeah, I
medications.
was talking to a guy yesterday that founded a company that's looking to, I guess, somewhat replace the role of the PBM, and I won't get too deep into that. But he had an example of a gout medication that was like $1 million for gout
Yes.
treatment. He's like, nobody's dying of gout. Now, granted, gout could be uncomfortable. There's flare-ups and things like that. But equate to me the value of $1 million drug for treatment of gout versus some generic alternative that's probably actually as effective or more. Who's prescribing that $1 million drug? And I don't know, maybe that's a random, rare example of an extreme situation, but it does happen. And if you look at medication or the pharmacy side of like an employer sponsored plan, they're typically 25 to 30% of
Hmm.
overall expenditures are on prescriptions, but that is trending at a higher rate. So the
Yeah.
share of prescription medication spend is growing faster than medical is growing. And it's for things like that. It's these random weird outliers that are
Yes.
hundreds of $1,000s or $1
Genetic
million bucks.
diseases
And it's not to say CAR T therapy or
yeah.
some of these like corrective, if you will, gene therapies that are curative don't do phenomenal things from a medical standpoint. The price tag is just so insane.
Yeah, I think some of that just goes back to the structure of how we do healthcare, with people getting, an exclusive on the market for a certain amount of time, and they know that, hey, we're the only ones on the market. We can jack the price up here to like $1 million per patient, and that patient, especially if it's like a genetic disease or something that's really rare, they have to pay it. There's
Mhm.
no way around it. It's either that or being severely disabled or potentially dying, and so it's like, life is worth more than money, so we're always going to choose life. But
Right.
still, that doesn't mean that we need to have a system that kind of abuses that position of
Yeah.
authority.
Well, yeah, especially because oftentimes the member is completely unaware of what the cost is because they pay their co-insurance or their co-pay for the drug, and they go about their day and they don't realize they're costing the plan $1 million
Exactly.
a year. And I was sitting in a boardroom yesterday, and I can't say where or with whom, but it's like they had one person whose drug spend was about 30% of their overall
Wow.
plan spend. 30%.
Wow.
And it's like, what do we do about this?
Yeah.
Because if you think about it, you stay in the traditional model where the PBM from the carrier has no incentive to change that situation, because what they now have is a pretense every single year to say, hey, we've got to raise your costs 30 or 40% for your insurance because you got that $1.5 million drug, which, by the way, is being administered in a hospital setting. It should be nowhere near that much money, but it is because nobody has the incentive to change it. And that person is probably unaware, maybe it's even a dependent, they're unaware that they cost the plan that money. But then you have a business going, we have
Yeah.
to solve this or our business is at risk.
Yeah.
And so I look at the other end of the spectrum, which is often financial. It's like, what if you're putting businesses in jeopardy of having to close their doors because one person's medication is so expensive? What do we do about
Yeah.
that, right? And what's the moral position to take on
Yeah,
that?
it's almost an ethical dilemma at that point.
Yeah.
Of like, what do we do with this where you don't want to deny care? You can't deny care to a patient, but it's also like if the whole business is going down, like there's no good option here. And so
Do you think there would be public benefit from some sort of government run or public risk pool for these extreme outliers where there's a pressure valve release for employers that are stuck in this situation?
yeah, I think that's an interesting proposition, is to have, almost like a government stop loss on some level,
Yeah.
where it's like, hey, if you are in one of these categories of diagnoses or, people that need this drug, the government will cover it. And I think what we have, at least I'm not necessarily a proponent of the government
Me
handling
neither.
our
That's why
healthcare,
I'm struggling with this.
but I think the
thought.
government does have a part to play where some of this monopolization of medicine, and we've seen that in PBMs, we've seen that with health systems now, and we see it with these specific drugs that get a monopoly on a certain, disease for 5 or 10 years, and they get to just name
Run
the
amok.
price.
Yeah, yeah,
And so I think the government does have a specific part to play in these types of situations where there's a monopoly, and the government can come in and make regulations to say, hey, you are not going to charge this drug over X whatever margin or
Yeah.
whatever it might be.
Yeah.
And having the government step in to do those types. I think that's the proper use of the government in healthcare, is to do some of these regulations where the free market does get out of control. But yeah, I still squirm inside a little bit when I think
I do,
about.
yeah, because I think about post ACA, the removal
Yeah,
of annual
exactly.
maximums and lifetime maximums, effectively giving hospitals a blank check to charge whatever they
Yeah.
want or need to because they know they're going to get reimbursed. That had the opposite effect of controlling costs. So then I cringe every time I even suggest this idea. But let me use the example of hemophiliacs. We regularly come across situations where there's a hemophiliac or multiple sometimes in a family on a plan. And those drugs can range from $6 to $800, $1 million a year. And they're ongoing recurring medications that need to be taken. So it is a sunk cost ultimately. And there's very few solutions from sourcing. Maybe there's some patient assistance that they financially qualify. But that employer is effectively stuck in that
Yeah.
situation, right? That is a great example where there is no real good uniform solution to lower the cost in a situation like that. So therefore, could we have a salve, if you will, or a government risk layer and a captive, whatever you want to call it, where at some point the free market doesn't pay for it, if you will, and the taxpayer absorbs the cost, and that's spread across 150 million taxpayers. I don't know if that's the right answer or not. I'm looking for a solution as things continue to spiral upwards in cost.
Yeah.
At some point, the private sector can no longer bear the brunt of that.
Yeah, I think the more like root thing you can get at that the government can help with is policy. I think there needs to be better policy around how people price these drugs, because they shouldn't have open access to just name their price and then have a monopoly on that space, because the patients have no choice. There's no choice there about where they can get it from. There's no choice about how much it's going to cost. And so I think that's where further upstream, what I would like to see is policy around some of these manufacturers are not allowed to just name their price. It has to be a reasonable multiple on how much it costs to make the drug. And I know there's R&D and there's years of clinical trials that go into that, and there's some way to formulate to say how much this costed to make. And you start to see people like that, like cost plus drugs pop up
Yeah.
and stuff like that, where we're seeing people take more of a, hey, it's just going to be a flat 10% of whatever it costed, and where that's going to be our margin.
Yeah.
And so I would like to see something like that more than, some private market, ability to create a better stop loss or captive.
Why don't we just have somebody like Elon Musk? Like
Yeah,
he could be
exactly.
the one that creates that risk pool.
Exactly,
Yeah.
yeah.
That way it's still private, right?
Yeah.
Having spent years working alongside healthcare leaders, brokers, and employers, I know how overwhelming healthcare can feel for our customers. We've all been there. Those renewal conversations that never seem to get easier. Rising pharmacy costs and medical costs, and no real transparency into where healthcare dollars are going. That's why I'm excited about Nomi Health. They're not just fixing the old system. They've rebuilt self-funded benefits from the ground up. With Nomi's network, you can offer something truly different. No copays, no deductibles, zero out-of-pocket costs when members see a provider. It's the kind of benefit that makes everyone ask, why hasn't healthcare always worked this way? Ready to bring your clients something different? Visit nomihealth.com and see how Nomi is rebuilding healthcare, one employer and one community at a time.
But so let's kind of zoom out then. I think that's a good segue into like a big picture stuff. So as GAM evolves over the last decade, as you're planning for what's happening, whether it's policy-wise or reacting to the market, what's changing, what do you anticipate happening in the next couple of years in healthcare, like the big stuff?
Yeah, good question. I think some of what we've touched on is, it feels like the last 5 years has really been like a price transparency revolution with all the, the executive order that came out in Trump's first term, and Biden reaffirmed that with making the penalties larger for non-complying hospitals and payers. And I think we're even having more strict rules that are going in here soon. And so I think it's been an awesome wave of like pricing data becoming available. So we now know how much does it cost to go get this or this done at these different facilities. And I think over the next 5 years, what I really see is happening is people now care about the quality of care. And so I'm really excited to think about maybe in 2030, the healthcare in the US has a market where people are freely shopping for care, and they know what they're getting and how much it's going to cost, and whether or not it's recommended by groups like us or even other patients that have seen that doctor. And I think of an end state in healthcare here in the US here soon, where people can freely shop for care
Yeah.
and have the right things at their fingertips to make a better purchasing decision than what's happening now.
Well, I think it's one of the biggest stains on our reputation as a country, unfortunately. I mean, I set aside the obvious innovation, set aside the obvious fact that a lot of people in different healthcare models will travel to the United States if they have the means to get care, whether it's because it's faster or the care is perceived as better. We can accept those things as true, and at the same time look at the system that we have and go, man, that's incredibly inefficient. It's incredibly costly, and it shouldn't be this way. And sometimes I feel somewhat embarrassed about this is the system that we have.
Yeah.
I would love to see where we get to the point where we're sort of proud as a country of we have created the best healthcare system in the world.
I think we have the opportunity to do that. People are, and I've been in that camp for a long time of like, people are really just pessimistic about how American healthcare is. And I think there's a million examples of why you could feel that way. But I think we have an opportunity to have a really beautiful healthcare system that the free market works in a really healthy way for. And I think also I see a lot of movement towards even further upstream than just shopping for care when you need care. I see a lot of movement also upstream to say, how do we make sure these patients don't end up needing this like super expensive care? How do we get in front of, diet programs and making sure that we reverse type 2 diabetes? And that comes with some innovations. Like I think the GLP-1 drugs have helped a lot of patients kind of reverse some of those risks. But I think it's also just, I see a big surgence of like lifestyle factors and people really caring more about their health. And so I think that's ultimately what I think gets us to a place where we're not paying for so much healthcare at the end of the day because people are healthier. And I think that's
where I always end up getting to. Eventually I get to the point where it's like human beings need to be healthier. Americans need to be healthier. Everything we're talking about is post the development of some chronic disease state, or an emergency acute situation because you had a heart attack because of 20 years of bad eating and being overweight and sedentary. Like until you ultimately convince and create a world where the population itself can be healthier, the rest of this stuff is kind of secondary to that.
Absolutely.
That is also a generational or multi-generational thing that will happen. That's not going to happen overnight either.
Yeah, and I think you're starting to see in the popular sphere of discussions now, thanks to some of the new voices that are in healthcare now, I think that we're starting to see people talk about the health of our soil and things of that sort, where it's like, why is it that you eat a pizza here in the US and feel like crap, and then you can go to Italy and eat pizza all week and you feel light and easy and you don't have eczema and you don't have breakouts. And there's something fundamentally wrong with the way we're doing food and our crops here in the US that I'm glad there's now, I think we're still far away from a true solution, but it's good to hear that people are starting to talk about it.
Well, the episode by the time this releases will be out, but I'll tell you now, we had Chef Austin Simmons. He's out of Houston. But like Rogan mentioned him at some point on because he went to his restaurant and just raved about it. But he came on the show to talk about how they're combining two different breeds of cattle to like create the best macronutrient profile. And it was really fascinating, but it comes down to how the cattle are raised, what's the lineage of the cattle, the soil that they're raised upon. And it's almost like, how do you reinvent the food distribution and production system that orients us towards a healthier population over time?
More local. I think it all has to go more local. We have great manufacturing across the country for cornfields and cattle, but I think the more local you can eat, the better it seems to be. And I think I live in Austin.
Yeah, I was gonna say, coming from Austin,
there's a lot of that's available, but you go to other cities, a lot of my family lives in Tulsa, Oklahoma. It's like, there's very little of that available.
Well, I mean, I was in Little Rock yesterday, and I'm not picking on the city, but I'm in the airport, and my options were Chick-fil-A or Chili's, right? And so you're hungry and go, well, I guess the best of two evils, I pick one, but it's ultimately there wasn't great food there. And when you have this massive, and I'm getting us on a tangent, we'll close the episode, but like a massive infrastructure of how do you feed 350 million people across a huge geographic area with bad incentives and subsidies for like unhealthy foods. And then you have most of the food coming from a few sources and they're just getting repackaged and recooked for different front-facing restaurants, but they're all coming from the same source. You go, there's no wonder we're so sick, man. All right, so closing thoughts, Will, as I took us on this winding like road there for the last couple of minutes. Summary of the episode or what you want people to think about that have stuck around this long. what is GAM, or what do you want them to close and then go about the rest of their day thinking?
Yeah, thanks for giving me the opportunity to come on here and
course.
get to know you a little bit.
Yeah.
Been super fun day together. I feel so passionate about just that central question. How do you get people to the right doctors? How do you get them to the right care that's, cost efficient, as well as just you're going to get the appropriate treatment by them. There's no risk there, and you're going to get high quality care. And so, really, what we're trying to do at GAM is bring a really fresh voice and perspective to measuring those things and creating resources like care navigation to plug into self-funded employers or other groups so that we can really help your patients get to the right care to make sure that they're getting high quality care, appropriate treatments at a low cost. And that feels like my life's mission right now. And
Cool.
I'm really thankful to have an opportunity to come talk about it
Yeah,
with
I'm
you.
grateful to spread awareness. I mean, I'm glad we got connected, and thanks again for making the trek. And tell Marty I said what's up next time you talk to him. But this is the kind of stuff I love to feature, man, because I really am focused on what is actually going to move the needle like massively in the right direction. And I could see if this grows and proliferates the way that you envision, it could have a role to play in doing so.
Absolutely.
So thanks for doing what you're doing, man. And again, maybe we'll revisit this in a couple years down the road, but I wish you the best of luck.
Thanks, Spencer.
My pleasure.